The following webinar was recorded as part of the original implementation of IWISH and has been made available for informational purposes only. Some portions of the original recording have been cut to ensure participants' privacy. References to the Lewin Group, implementation team, site liaisons, PHL, Google Drive, and some forms are not applicable to the demonstration extension effective October 1st, 2020. Terms and conditions of grantee's cooperative agreement supersede any information presented here. Please see the IWISH Operations Manual for the most up-to-date implementation information.
All right, it is time for us to get started. Good afternoon to some of you and good morning to others. Thank you so much for joining us for today's webinar, Supporting Tough Conversations with Older Adults, Their Caregivers, and Family Members. Next slide. Today, as you listen and as we go through the next couple of slides, this is what we hope that you're able to take away from this presentation, that you'll be able to understand the factors that make some of the conversations more difficult than others. So why is it easier to talk about X versus Y? Be able to outline a process to plan for tough conversations. So you don't want to just jump into the tough conversations. How do you prepare yourself and maybe even the resident or the caregiver for the conversation? What are some things you can do ahead of time to get ready for it? And then finally, we want to describe strategies for addressing sensitive topics with residents and their family members. So what are some phrases that you could use? What kind of environment can you create in order to make the conversation easier for both you and the resident and their family members? And then one more thing we'll also go through today is we'll talk about the CHAP, the Community Healthy Aging Plan. Many of you have already received your community profile, so today at the end of the presentation, we'll talk briefly about how you use your community profile to create and develop your CHAP.
Family and make important decisions about health and wellness. Next slide. Sensitive issues do come up. Here is a list of a number of them. Working with an aging population can be really rewarding, but there are also times that topics come up that are extremely sensitive for you or for the resident or both. And these sensitivities might be inherent in a broad population, but when you take into account culture and background and other social determinants of health, the sensitivities can really increase or decrease. So it's imperative that as IWISH staff, you're committed to having these conversations as they come up. They not only support the IWISH goals, but they also enable the participant and or the family members or caregivers to have improved quality of life while building trust with you. And along with the issues that are listed on this slide, the sensitive or difficult topics that you have been thinking about in some of those areas may be difficult to discuss with people that we're working with. So we're going to talk about a few of these topics specifically and all of them more broadly today. And as we talk, if you have anything that you want to add to the conversation or you have a question about, just let us know in the chat. We want to make sure that the hour is beneficial for everyone. Next slide. So as discussed, sensitive issues will come up with IWISH participants. And to best support the participants, it's important to plan for the conversations as much as possible. Next slide. What makes some conversations more difficult than others? Well, there are a number of different things. And, you know, one thing that happens a lot is that you may find that you need to be more direct than is usually considered polite. So your parents may not approve of what you have to say with the resident. And their parents may not approve, and they may not approve. So you're going to want to couch the content in ways that feel less intrusive, less disrespectful to the person. All of these things are going to vary based on social norms, race, ethnicity, socioeconomic status, Cultural competence is a big issue here. So the more culturally humble you are, and the more you are able to ask about the person's culture, ask questions, and take the answers into account, the easier it will be to have these conversations. Next slide. We often make assumptions about how the conversations are going to go before we even get started. And part of this is about being prepared for what we think might take place when we discuss these points with people that we're working with. We think about what we've observed in them, what we understand their values and preferences to be, and how conversations tend to go with them. But we may or may not be entirely accurate in our expectations when we just base the assumptions on our direct experience with the person. There's a big push right now in healthcare to make healthcare systems what they call age-friendly. And there are, they refer to the 4 M's in healthcare. And the M's refer to mobility, mentation, which is about how the person is thinking, medication, and the pivotal one for us, which is what matters most to the person. So what matters most is about taking the person's wishes and values into consideration and basing care on what the person desires. To understand the person, healthcare systems are encouraged to ask questions like, what's important to you today? What brings you joy? What makes you happy? What makes your life worth living? And what do you worry about? It can help if you utilize this what matters most perspective in working with your residents. And I'd suggest that you listen really carefully to the responses and then ask some follow-up questions. That way you can incorporate this into your plan of care so the person's going to feel heard and feel responded to and feel like the plan is taking their preferences into consideration. Now this is a process. It's not just a one and done. You're going to be continuing the conversation throughout the time you're working with the person. One other factor to take into consideration here is your own personal hot buttons. We all have them. We all got issues that tend to trigger responses in us that can get in the way of us being as responsive as we possibly can to the people we're working with. And the more we know ourselves and understand what tends to trigger our reactions and where those come from, the more we can work those issues through and avoid reacting in ways that are more about us and less about the resident you're working with. We want to understand our reactions to the point where we're really familiar enough with our automatic thoughts and feelings that we can sort of say to ourselves, oh, right, that again. I know that feeling. I know where it comes from. I'm just going to set that aside for now and refocus on what I need to be discussing with the person. And this is a technique that is sort of, is something that we're going to be talking a little bit later about, and something that you can use with your patients or your residents and teach them to use. Those feelings that come up function as caution flags for us, and they tell us to take a moment to set our own feelings aside and to intentionally focus ourselves on the work we're doing with the person and on helping them with their own needs. Next slide. So one thing that makes some conversations more difficult than others is this tug of war that goes on between two parts of our brain, the amygdala, which is responsible for emotions, and the prefrontal cortex, which regulates emotions and controls executive function and reasoning. The amygdala coordinates responses to stimuli, and it plays a big part in emotion. We have a biological response to emotional threat. So our heart rate goes up, our breathing escalates and goes faster. We start talking faster. If we're in a conversation where emotions are running high, we can't think really clearly, and neither person is really listening to the other person's points. Now we see this sort of change happen when someone is undergoing persistent stress or fear. Dr. Nadine Burke-Harris, who is a pediatrician, refers to this in her TED Talk and in her writing. She discusses how we're programmed to react if, for instance, we're being chased by a bear. And this goes way, way back to how we've evolved as a species. Our heart starts pumping more blood to the brain, reaction times quicken, our pupils dilate so more light can be taken in, and our adrenaline is released so we can either fight the bear or run faster away from it. And then she says, now imagine the bear comes home every night. This kind of stress in childhood has been shown to have a huge impact on functioning in later life. It's not about a bear coming home, it's about a parent or a sibling coming home, and it immediately puts kids at tremendously increased risk for a variety of negative health outcomes. It also programs people to respond to stressors, including challenging conversations, as if it were a danger, and the old established coping mechanism kicks in. So to succeed in difficult conversations, you're going to want to begin to engage intentionally instead of responding in ways that trigger your own amygdala's response. And it starts with practice. As you start engaging in conflict intentionally, you're going to get better at it over time. And as you practice more, you're going to be more confident and more likely to do it. So we'll talk about how to make that happen later in the presentation. Next slide. It's great to have a plan for handling difficult conversations. So we'll talk about some tips now. Next slide, please. The first tip is don't put it off. Sooner is better than later. So the longer a conversation goes undiscussed, the easier it is to sort of put up defenses about that conversation. It can increase anxiety to put it off, and people can also develop all kinds of assumptions about what's going on or about what might be going on in the conversation when you have it. It's a good idea to write some notes about what you want to say and to practice in advance, and then plan for a time when both participants are rested and feel comfortable. Next slide. Next, there we go. You're going to break the conversation into parts. So you don't need to address everything all at the same time. And you know, you're going to be going at this little by little. A good way to set the conversation up for yes responses is by asking the permission of the person you're talking to discuss what you've noticed. So this sort of comes from motivational interviewing techniques. If you're able to ask the person, would it be okay if I told you a little about what I've noticed, and they say yes, they're much less likely to get immediately put off by what you have to say than if you just jump into it without any kind of question about getting the person's permission. And, you know, once they've already said yes, they're more likely to kind of lean into the conversation instead of pulling back from it. Next slide. Another tip is to start by asking questions, other kinds of questions. Like, I've noticed some changes that concern me a little. I wonder if you've noticed anything similar. Or what has your experience with this issue been like? If you can get the person to make some statements about things that they've noticed that may be similar to what you're going to want to talk about, that will put you steps ahead. if they say, no, I haven't noticed anything like that, and neither has anyone close to me mentioned anything to me about it, then you can say, well, sometimes it's more difficult to notice these things in ourselves than it is for someone else to notice them. So would it be okay if I talk to you a little about some of the things that I've noticed? Next slide, please. You can also normalize sensitive topics by kind of letting the person that you're speaking with know that their experiences are somewhat common, that they have had these experiences and that you've heard it from other people as well. You can also mention that a lot of people notice problems that are typical of aging, but they might signal that something else is going on, and that you may want to have this discussed with the primary care physician. Next slide. Each person is the expert about themselves. Compassionate curiosity is a way of interacting with people that acknowledges that they're the experts about themselves and everything that has influenced them to be who they are today. Although this is a term that's often used to discuss how to connect with people from other cultures, compassionate curiosity can also refer to curiosity about a person's culture, regardless of how similar or how different it is to our own. We can use compassionate curiosity no matter what the person is talking about, what their context is, or what their experience has been. We're going to ask them to tell us about themselves, a lot like you do when you have your IWISH person-centered interview, when the person has first come to you, and then annually after that. So first, you're going to acknowledge the other person's emotions in the beginning. You might say, you have a right to be upset, or I can see why you'd feel frustrated. This is about empathy. It's important to be empathic with the person. If someone's empathic with you, you're far less likely to respond with anger or defensiveness. And it's good to keep in mind that the person's truth is your truth that you have to deal with. Start by displaying your understanding of this. With this strategy, we're quieting the amygdala of the person so we can speak to the prefrontal cortex. Emotions can really be a legitimate barrier in these difficult conversations. If you acknowledge that and get it out of the way, you're going to be able to move on to the substance of your conversation later. Whenever the person responds with anger or defensiveness, you can end the conflict by focusing on an empathic response. And this is going to cut this amygdala-based response. There is no danger, and the person can re-engage with the prefrontal cortex. Then you can start to use motivational interviewing to develop a plan together. If they're on the fence about an issue, don't attempt to convince them. Motivational interviewing suggests that you join them on the fence and explore the view from the fence together. So instead of getting into an argument, you're going to join the person on the fence, look around, and talk about what you're seeing from their perspective. You can ask questions about how the person thinks or feels, and remember to use the ORS technique, which is open-ended questions, affirmations, reflections, and summaries. So if and when you want to provide some information to the person, you can say that you have some information about the topic and then ask if they'd like to hear about it. Understand, though, that when you ask that question, they may or may not want to hear what you have to say. You need to realize that it's okay if they say no, they don't want to hear it. If you give the information anyway, the person's going to demonstrate to you that they don't want to hear it. They will show you, and the relationship is going to be negatively impacted. So that it's going to be much harder after that to move the conversation to a place of acceptance. So if they say no, just remember, this isn't your only opportunity to have a conversation with the person. And it may be that they'll be more receptive at a different time. Next slide. You will want to use words that are comfortable for the person. Many times people are very uncomfortable with the phrase Alzheimer's disease. No one wants to have Alzheimer's disease, and people don't really want to talk about it much either. So if you can use the phrase memory concerns or some concerns about functioning, it may be much more palatable to the person than talking about Alzheimer's. You can let the person know that you're there for them and then express your specific concerns about what you've noticed. Next slide. So this is a good spot to think back to what matters most to the person. The more that you can incorporate those preferences and values into your conversation, the less resistant the resident's going to be. It can also be helpful to incorporate the voice of someone that the person holds in high esteem. So a good example of this is when someone needs to retire from driving. This message can come from family members, friends, you, other professionals, and the person may figure out ways to argue with whoever is trying to convince them that driving is dangerous for them. But if you add a doctor into the conversation, things will often change. Very often, especially with older adults, the person can hear the very same message in a very different way if the message comes from the doctor. So you can reach out to the physician and ask them to tell the person that based on their assessment of the person's functioning, they're no longer able to drive safely. This message can be reinforced by the doctors writing it on a prescription pad. It makes it feel much more official to the person. Clergy members often carry the same sort of power and ability to sway the person. So you might want to consider including them when you can. Clergy can especially be powerful assistants to you when someone's resisting taking an antidepressant medication. Sometimes people feel as if it goes against their reliance on God to help them, or goes against their spiritual beliefs. So if a clergy member is comfortable with medication, that person may be able to help you reinforce the idea that it's a good idea to take medication. Next slide. Having common difficult conversations about specific issues is what we're going to be talking about next. Next slide, please. When we work with people with disabilities of any kind or compromised functional abilities in general, a lot of our work excuse me, has to do with trying to ensure the person's safety while we allow for the most independence possible. Family members often put a really high premium on safety, and the person we're working with may place a higher value on independence than on safety. And this can put us at odds if we aren't careful in our approach to discussing these issues. For your residents, there's also the safety of other people to think about. Safety of other residents may be a consideration. Independence is something that we want to encourage, but when it infringes on the independence of other people, there can be conflict. It's important to encourage the resident to see it from another person's point of view, often yours. But it's very hard to get someone to do this when they're fighting against your wish to have them go outside of themselves and see it from another perspective. So remember that one way to get out of a power struggle is to simply stop struggling. You may want to start talking about what both parties have in common, and compassionate curiosity is useful. We start by acknowledging how difficult the balance is to strike between safety and independence. And then you can go on to talk about how for some people, safety or independence is more important than for other people. You may want to ask the person to rate how important it is to them on a scale from 1 to 10. And you can do the same thing with safety. And then you can ask if you can work together to see if you can develop a plan that takes their preferred balance into consideration. Once you're able to demonstrate that you care about the person's preferences through compassionate curiosity, you're going to be conceived by the person as much more in sync than if you don't take that step. And the person may see you then as an opponent instead of as an ally. But when you talk about your needs regarding safety and independence for the resident as well, then you can discuss this in a more personal way. It's also a good idea to use yourself in your work with the resident. And that can move you from the position of a parent or authority figure to someone who cares about them and their needs. So you can each rate your degrees of importance regarding independence and safety for the person, and then kind of negotiate from there. It can help to let the person know that you want to think creatively together about how to provide the person with the chance to be independent while still operating within the guidelines of the program. So all of this applies to working with family members as well. Understanding their perspective and demonstrating that you put a high value on their perspective brings you closer together before you even start talking about any kind of topic. Next slide, please. So now let's talk about some of the most difficult conversations to have with older adults. One conversation in which you're discussing balancing safety and independence is about retiring from driving. And retiring is a term that I think feels less adversarial than giving up driving, or even worse, taking away the car or taking away the keys. So here are some steps to take to make the conversation flow more easily if you've noticed that the person may not be safe to drive anymore. First, start with the compassionate curiosity pieces that we just talked about. And next, ask if you can talk about the behaviors that you or other people have noticed. If the person agrees, talk about what you've seen and why it concerns you. And then tell the person that the changes may be due to different things. It can be related to age. It can also be a side effect of medication. It can be an indication of cardiovascular problems or a vitamin deficiency. And that's why it's important to talk about these changes with the doctor. You can remind the person that someone who is a calming influence or a provider of emotional support can go with them to the appointment. You can plan to pair it with something that the person enjoys, like a lunch out together afterward. A key point here is that even if the person cares less than you do about having an accident, they're typically not wanting to harm other people as a result of having a collision. And this is not something that most people think about. It goes a long way toward persuading someone to rethink their behavior if you just point out that you're sure that the person doesn't want to injure themselves or to injure anyone else. And finally, let the person know how much everyone cares about making sure that the person gets to the places that mean the most to them, and that you've discussed how to ensure that that happens. So this is about the planning ahead of time. Plan for how to get the person to wherever is most meaningful to them. Next slide, please. So on this slide, you're going to see an explanation of a conversation when it's clear that there's a memory issue and the resident refuses to accept or seek any kind of medical care. Imagine that someone's telling you that reality as you know it is not actually real, that what you see or hear or remember is not accurate, that you didn't grow up where you think you did, or that your life partner is actually someone other than who you think. You would never believe them. Well, this is exactly what happens when you try to tell someone with memory issues that what they remember doesn't reflect reality. This is why you get so much pushback from people with memory concerns or executive function issues. And yet, on some level, they may know that the memories that they're having aren't what they used to be. When they defend against it, they're going to sometimes pretend that they remember things that they don't really. And what can you do about this? The best thing is not to argue about the facts. And you're going to want to get the person to see a doctor to see about what is causing changes that you all have noticed. Arguing about the cause is going to get you nowhere. It can be really tough, though, to get someone to see a physician about their memory. If Alzheimer's disease has overtaken cancer as the most feared disease among Americans, you can just imagine how much somebody who has some of these symptoms is going to be denying it as much as they possibly can. The loss of the sense of self that can accompany a dementia-related disease is terrifying to most people. And the first way that we learn to defend ourselves against something scary as little kids is to deny that there's a problem. A child whose face is covered in chocolate and who is asked over and over if they've eaten the cookies are going to get more and more entrenched into their response that no, they have not. Denial is a really primitive defense, and we use it all throughout our lives, even if it makes no sense. So arguing with someone about what they see or don't see and about their memory concerns is pretty pointless, and it usually leads to upset feelings instead of to any kind of an agreement. Compassionate curiosity is a pretty powerful tool in most situations, but when somebody's really resistant about seeing a doctor about cognitive changes, it's sometimes best to just avoid the argument altogether by communicating directly with the physician. Now, many people think that this is not possible to do because of HIPAA laws, but HIPAA only covers a physician's conversation or a professional's communication with someone other than the patient about the patient. You can always give information to a physician without compromising someone's HIPAA rights. So it's just getting the information back from the professional that causes a problem. Calling, writing a letter, or sending an email are all good options to get your concerns conveyed to the doctor before an appointment. Now, getting a person to an appointment is also an issue that can be dealt with in the next step in the process. One way to do this with someone who insists that there's no need is to set up an annual wellness visit with the physician. The annual wellness visit is an appointment that's scheduled to develop or update a personalized prevention plan so that the patient can stay as healthy as possible. It's free of charge to everyone on Medicare. You can help ensure that the cognitive screening is done as part of the annual wellness visit by conveying your concerns to the patient's primary care physician and asking for the basic cognitive assessment to be included in the visit to see if the person needs to be seen for more thorough assessment by a specialist. Be sure to have someone go to the appointment with the person, and the person accompanying should feel familiar and supportive if the resident is resistant. Following the appointment again with a shopping trip or a movie can go a long way to reducing that resistance. So next slide, please. How many of you have completed your own advanced directives paperwork? This is with respect to medical care. Advanced directives include a living will, durable power of attorney for health care. Some states also include physician's orders for life-sustaining treatment or POST. In some states it's called medical orders and then it's called MOST, or the 5 wishes documents. Other types of advanced directives are non-medical in nature and govern the person's finances. So how many of you have completed these documents? If you have completed the documents, think to yourself about what the process is like, what it was like when you did it, what it took to navigate all the documentation, and how it made you feel. If you haven't completed the documents, why not? How can you use your own perceptions and thoughts about it to inform how you interact with residents about it? It can be sort of the last thing on earth that some of us want to do, especially if we're young, but for all of us, regardless of age, it's really important to fill out these advanced directives. If there's an accident and something happens and we're not able to talk about what our preferences are or what we'd like to have happen to us, then people are going to need to make decisions in a hurry. Next slide, please. So advanced care planning is going to ensure that the people who the resident chooses or who you choose will be the ones making those decisions. This is going to allow decisions to be made by people who know what our preferences are. The IWISH staff can be supportive of residents in discussing advanced directives with primary care providers. And so to have this conversation, it's important to emphasize the importance of being proactive and to normalize the topic. This is a really important issue, especially for people who have developed families of choice rather than biological families who they would select. And it's important for people who would prefer to have people outside of their family of origin to take on some of these roles. Next slide, please. Other sensitive topics to be aware of include rehabilitation from a fall. A fall can be kind of a sentinel event. It can be a signal that additional difficulties may be on the way. This can be really difficult for residents to listen to, hear, and take in. So it's a good idea to approach the topic gradually and to be really sensitive to that, using compassionate curiosity as you start to talk about these issues. The biggest component to discuss is denial. Denial is part of what keeps substance abuse active. The irony is that if someone denies a problem with substances, it may indicate that there is a problem, or it may indicate that there's no problem at all. So motivational interviewing techniques can be really invaluable in talking about this issue with your residents. Keep the resident in charge of the conversation, and again, join the person on the fence, discussing together with permission what all sides of the issue are. This is best to do as dispassionately as you possibly can, and it requires that you not fake the curiosity about the issue as a way to get the person to see it from your standpoint. This is not about how to get you to your goal. It's about partnering with the person who's the expert on themselves to see what may fit and what may not. They may not want what you want, and that can be really difficult. But the more that you sort of empower your residents to make decisions for themselves when they're cognitively able to do so, the easier it will be. If sexual practices are discussed because of potential promiscuity or unsafe behaviors, it's a good idea to approach it from an educational standpoint, again with the resident's permission every step of the way. This is also an issue of safety versus independence. So the tips that I talked about earlier apply here too, but the issue is much more personal than an issue like driving. This also incorporates the person's view of themselves, their self-perception. It can be helpful to talk about the issue from an acceptance and commitment therapy standpoint or ACT standpoint, where you're in discussion about whether the feelings and the behaviors lead the person toward or away from the values they hold. And the next slide shows how you can do that pretty easily in a meeting with the resident in a non-threatening way. Next slide, please. So this is a really easy graphic way of helping somebody sort out which thoughts and feelings and behaviors move them toward or away from their values. And this is something that I really like using with patients who may be somewhat conflicted about how they feel or have no idea what they want to do about answering certain questions for themselves, like what should my next move in my work life be? So you start by asking the person what matters most to them and what sort of person they want to be. What characteristics do they hold dear? What would they like to develop more in themselves? So you list those things, and then you take a look at those components and what they're doing in their lives regarding work or education, spending their leisure time, their health, their personal growth, or their relationships. And as they mention something, you ask them whether that moves them in the direction of their values on the left, where it's toward, or in the direction away from their values, which is on the right. And you write it in that quadrant. So thoughts and feelings that lead them toward their values go in the upper left-hand corner. Thoughts and feelings that lead them away from their values go in the upper right. And then actions that lead them toward go in the lower left, and actions that lead them away in the lower right. Next slide, please. So let's take a look at sexual behavior. The matrix that you can develop together may look something like this. So thoughts and feelings that lead them toward may be companionship, feeling supported, feeling understood, feeling accepted. Actions that lead them toward their values may be being with people who like me, getting out, seeing new things, new relationships. Things that lead them away from their values, thoughts and feelings that lead them away may be feeling taken advantage of, guilt, feeling defensive, feeling like relationships are fake. And then actions that lead them away may be getting false compliments, disrespectful behavior, dishonest behavior, manipulating people, or lying. So you're going to take them through any new situation and put them through this matrix. And what you'll see here is that anything that is to the left side are things that lead them toward their values. On the top are thoughts and feelings that lead them toward their values, and on the bottom are actions that lead them toward their values. So they're going to want to maximize those things and then to minimize the things that are on the right. So if you know, a decision needs to be made about whether to date a particular person or whether to go out for drinks with a particular person. You can have them put it through this matrix. Does it lead them more toward or away from the values that they listed on their matrix? And this can happen with any kind of situation. You'll stress that you can work with the person to help them live in a way in which their thoughts, their feelings, and their actions move them toward their values, and help them eliminate things that move them away from their values. So you're on the same page with them. So they will still want to do those things that are on the left side and reduce those things that are on the right side. And this allows the person to do the work themselves of deciding what feelings and behaviors to pursue or get more of and which ones to move away from. Next slide, please. So now we'll move to talking a little bit about communicating with family members and caregivers. Next slide. Building trust. Families can be tremendous supports for your work with your residents. Working with them, though, can be a challenge. These relationships work best when you listen and demonstrate that you want to include them in your work with your residents. So on this slide is a list of some of the things that can help family caregivers feel included. The final one about being available to them to discuss any concerns they may have is probably the most important one on the list. It's a good idea to make a point of repeating this every time you talk with the family member, that you have an open door policy, a just ask policy, and that they're welcome to talk with you and ask any kinds of questions that they have. Next slide, please. Communication is key, but you're going to want to be really clear about balancing the desire for information about the person with the resident's right to independence. So keep in mind that you need to have the resident's consent for this. You're talking about the resident's privacy, and this has to be foremost in your mind when you're working with family members. So make sure that you get their consent before you engage in any of the other components. And that you would like to share the information with everyone who's involved in order to work together effectively, but you're not going to want to reveal everything about the resident's life. The easiest way to manage this is to have the resident do most of the talking about their personal concerns, with you as the mediator and you as the encourager. Your expertise is about your program and about the stress of caring for an older adult, the pressures on their roles, and the complexities of balancing safety and independence. Next slide, please. You're going to want to respect the family members and never judge their circumstances. Families come from all different kinds of backgrounds. And those backgrounds are really the backdrop against which all our work is done. The cultural traditions and the religious traditions of a family can dictate a lot about their values and their preferences, and we need to understand them as much as possible to respect them. So how do we do this? By demonstrating cultural humility rather than cultural competence. Cultural humility is about taking the time to ask about the family's traditions and practices, and then honoring those practices and taking them into account in everything that we do. So we may think that we know a lot about a person's particular culture, but the way that it's played out in that family may be very different than what we think, or than what even is most common for people of that culture. So you cannot ask these kinds of questions too often. And it's important to remember those answers and to take them into consideration. Next slide, please. So what makes some conversations more difficult than others? Well, a huge factor is the belief that you need to do this alone. In fact, you actually have a team of people to assist, from social workers to physicians to family caregivers to community agencies. And the key to making the team work its best is communication among the professionals, with your residents, and with family caregivers. By doing your prep work, by setting the stage and conveying acceptance of the person's perspective, letting them know that you understand their feelings and their positions, and maintaining a posture of compassionate curiosity, you can engage the person in a really intentional way. And this way you can move conversations from being difficult to being reflections of the empathic connection that you have with your client. So at this point, I'll turn it back, and we can talk a little about questions you may have, or ways to apply the strategies that you learned about today in your work with your IWISH residents. Is someone able to pick it up from here? Okay.
Joy, are you on the line? You may be on mute.
I see something here that says this. I have several residents who say, I don't want to plan for illness. They have a primary care physician because that invites illness. Yep, they're very firm about their beliefs, very against traditional medicine approach. I'm not sure how to present the benefits of health maintenance practices. There doesn't seem to be room in the discussion for another point of view. I think that's very true, and there are cultures where this is pretty common. The feeling that talking about illness invites the illness, talking about death is taboo because it invites death. If the person is extremely reluctant to engage in the health practices that you think might be beneficial, you may want to get some reading material for them, just leave it with them and suggest that they read it and that they can discuss it with you if they have any questions. It's not your job to convince someone to let go of their entire history and their culture and their traditions and do it your way, even though you believe it to be right, and even if you think that the person may be suffering physically as a result. Now this gets into an issue of ethics too. When is it ethical to not pursue this with someone? And I think that sometimes, at least in the state of Illinois, we refer people to the state agencies to get self-neglect evaluations. And that's a hard thing to do if someone is not really interested in pursuing it, but it may come to that in order for you to protect yourself as a professional. Does anyone else want to comment on that?
Hi, this is Joy. So I was having audio issues before. I agree with what you're saying, Ellen, in terms of it is not the role of IWISH staff to force certain practices on the residents. That has IWISH staff be there to support them and help them age in place. And if there is reluctance to adopt healthcare practices that you know are good for the resident, that you know will help them to age in place when they don't have a primary care physician, then that might be an opportunity to call Adult Protective Services or get other people involved in helping the resident make the right decisions. And if they have family members, you also want to try to bring them into the conversation too. And if it's something related to their belief, Ellen, you said this during your presentation, if it's a spiritual belief, see if you can get in contact with the priest or the pastor, the rabbi, someone whose voice that they will respect, and see if that will help them to adopt the practices.
Yes. The other thing is that it may be that at some point you're concerned enough about the person's health that they're no longer able to live independently if they're not able to pursue getting some sort of health care. You know, that's a place to go to after you've exhausted all the other options. And if the person is really severely impacted, you need to protect your program and protect the safety of your resident, as well as respecting their beliefs.
Thank you. Before we move on to Emily, Ellen, I just wanted to share with you, earlier when we'd asked the staff to share some of the difficult and sensitive topics that they have to face, one of them that came up, a couple that came up were addressing issues of body odor, so kind of hygiene practices. So I was wondering if you had anything to add about that, or to any tips to share, and how do you address something personal such as hygiene practices?
Sure. That was one that came up in the beginning of my career when I worked with residential programs, and I know exactly what you're dealing with. I think that as much as possible, it's helpful to pull the person aside, do this in private, do it at a time when they're not racing out to try and get to a job or something, and to say that you have some concerns about the person that you'd like to share, and would they be willing to have a conversation with you about that? And are they interested in hearing what you've noticed about them? And then if you can get their consent, it's much easier to pursue that. It's hard having a conversation with someone when you're needing to say you really need to take a shower on a regular basis, you really need to be washing your clothes on a regular basis, or I'm noticing an odor. With people who are incontinent in particular, sometimes they're in denial about their incontinence. You know, the more you can kind of set this up for success by saying, I care about you, I've noticed something that I think is causing a problem, and I want to have a conversation with you about it. Is it okay if we talk about this? The easier I think it will kind of go down. And then you can help the person set up a calendar for showering or bathing and for laundering clothes. You can help them figure out how to get incontinence supplies if that's something that they're needing, and maybe stress the benefits of attending to this, that people will feel much more comfortable around them and want to be with them more if that's a value for the person. If it isn't, then that's not going to be helpful.
Thanks, Ellen. That's very, I don't have anything else to add, but that was very helpful.
Good.
We're going to transition to Emily to talk about the chat, but I just want to highlight one more time some of what Ellen said. One, the idea that you want to be prepared. So tough conversations, we know, are part of what you do in IWISH. And yes, they're hard and they're difficult, but they're so important and necessary. And it can be easier for you if you take the time to prepare. And part of that preparation is building relationships. That's why we have you do the PCI, the health and wellness, the group programming, because if you have a relationship with your residents and they see that you care, it may make it a little bit easier for them to receive what it is that you're saying. Additionally, you don't have to do it alone. Ellen said, we have a team. You have either your fellow RWD or wellness nurse talk about it. Practice having a difficult conversation with the family member or with the resident. And these, if you apply these strategies, I believe that you'll be successful in having these difficult conversations. We're now going to talk about the Community Healthy Aging Plan. Earlier in the demonstration, when we first started having these webinars, we talked about the IHAP and the person-centered nature of that, and we also briefly talked about the CHAP. Emily is now going to go deeper into what the CHAP is, the purpose of it, how to develop it, and how to use your community profile. And then we'll hear from one of your fellow sites, Vista Towers, about how they're developing their Community Healthy Aging Plan. Emily, take it away.
All right, thank you. All right, so I see a lot of you have typed into chat that you have received it. If you have not, please reach out to either your site liaison or the HUD IWISH inbox, and we can send those to you. But I want to quickly go over what the CHAP is. I know a lot of us have heard about this before, but just a quick refresher since it has obviously popped up in a lot of your inboxes. So the CHAP stands for Community Healthy Aging Plan, which Joy mentioned earlier in the presentation, and it lays out strategies for sites to address common needs, interests, and goals within your community. It's guided by information gathered from 3 main sources, as you can see listed on this slide. Those 3 sources are the person-centered interviews, the health and wellness assessments, and the Individual Healthy Aging Plan, or the IHAP. So the implementation team will generate a profile for your site, send it to you, and this is going to help support the creation of the biannual CHAP. And again, just as a reminder, if you have not received it, please reach out to your site liaison. So the first segment, I guess, of the CHAP is the community profile. So the community profile provides a starting point for you to help build your site's CHAP. And the community profile is the document that Joy mentioned that has all the nice graphs and charts. You should see the data in the community profile and use it to identify the priority needs and interests across your site. So this data, which was pulled from PHL, should be combined with your knowledge about participants from the PCIs, your interactions and conversations with your residents about what kinds of programs and activities they prefer and would like to participate in. And then this is all in addition to identifying which programs and activities will be most useful to your site. So on the slide, you can see all of the goals that the CHAP will help you reach. Some of these goals are improving well-being, improving health outcomes, reducing avoidable emergency department use, and the list goes on. So a main topic of this CHAP is the fact that resident-informed programming is powerful programming. So the community profile and the CHAP guide, which I will discuss in a minute, are all great tools that you can use to build resident-informed programming at your site. Information really is power, so when you're armed with this information about your site, you can use it to help the most residents possible. Now let's take a look at some of the graphs you will find in the community profile on this next slide. The community profile provides a picture of your IWISH community based on information gathered in the health and wellness assessment and the other 2 bullets that I mentioned earlier. It kind of gives a high-level overview so that you can see the common challenges that need to be met instead of going into each individual's information in PHL. This kind of gives you a nice visual representation of what exactly is going on at your site. So the information contained in the community profile will help inform at least 2 key IWISH activities, and that is developing the CHAP and the recruitment of partners that can help execute components of the CHAP or provide services and partnership to have successful programming at your site. The community profile contains graphs and tables related to the following areas, such as demographics, physical behavioral health, advanced directives, risk and prevention areas, medications, and insurance coverage. And you can see here examples of excerpts from 2 sites, specifically the participant ethnicity, race, participants with multiple health conditions, and mental and cognitive health condition exhibits. So now that you're a little more familiar with the community profile and what that looks like, this is the CHAP guide. So the CHAP guide contains descriptions about what each exhibit in the community profile shows. So you can use this in conjunction with the community profile to kind of get a better understanding of what each graph represents and what it means. And it provides information on possible programs or activities that you can use. So it kind of gets a little deeper into, now that you have the graph, what do you do with it? This slide contains a screenshot of what the CHAP guide looks like, and this should have been sent around in conjunction with the community profile. If you haven't received it, please reach out and let us know, and we can send that your way. So now that we all have an understanding of the purposes of each document, we're going to walk through just a quick example. So let's pretend that this is the result of my community profile's Exhibit 5. Exhibit 5 is the participant top reported health conditions. You can see here that 70.6% of my residents struggle with hypertension, and 54.4% of my residents struggle with hyperlipidemia. So diabetes, acid reflux, arthritis, and thyroid disease are also among the top reported conditions, but those 2 are the ones that I know are going to be a major focus at my site. So now that I have this information, what do I do with it? So since hypertension and hyperlipidemia are reported the most frequently, I know I need to focus my programming efforts on this. So I consult the CHAP guide and see that this exhibit shows the 5 most commonly reported health conditions and potential actions I can take, such as providing evidence-based disease management programs, education sessions, nutrition education workshops, vital signs clinics, fitness activities, and all of the other programs that could help with these 2 conditions in particular. I also see that potential programs and activities for hypertension include some of the same programs. So now I ask myself, now that I know that these 2 conditions are a focus for my residents, are there programs that I can look into bringing on my site? Are there programs that I'm currently hosting that I can amp up, sort of? So as I continue to think about new programs, I also want to enhance the ones I already have. Armed with this information, I will most likely choose to look into a cooking class or an exercise program, as these 2 programs address multiple challenges at once. So now that we've discussed how to use the community profile and CHAP guide together, we can put them together to develop the CHAP template, as you can see on this slide. So after you think about what kind of programs or activities you want to pursue, you want to start planning the actual implementation of these programs. So asking yourself, who is going to provide the program or service, how is it going to work, and who will benefit from these programs. There is a blank template in the CHAP guide that you can use to just start filling in, as this is an example of one of the completed CHAPs. So once you begin to fill in your information, your CHAP template should look something like this. You can see the program title and brief description, as well as scheduling information and any notes about the purposes or needs of the program, and other information just to keep you organized. We know that some of you have programming that you're currently hosting or planning, and that has grown out of what you've been finding out about your residents' interests, or that they've expressed to you, and you can feel free to incorporate this into your existing template.